title of the presentation is Brodie's Abscess, a Diagnostic Conundrum. This was a case report written by myself and three of my colleagues at Luton and Dunstable University Hospital, Luton, Great Britain. So introduction. So what happened and how did we come about this interesting case presentation, basically? Yeah. So Brodie's abscess is defined as a subacute or acute and chronic osteomyelitis of the bone. And it is an uncommon condition, not very commonly seen. And it is usually mistaken for a bone tumor. And it's frequently observed in the tibia, metaphysis of the tibia, or metaphysis of different bones, especially tibia. And it's a condition that commonly affects children. Why is it a challenge to diagnose? Basically, what happens is a child would present to you with atraumatic limb pain, and you don't find any other alarming features. You don't find any other symptoms that would make you investigate it further. The child is afebrile, the bloods would be fine, the inflammatory markers would be okay. He wouldn't be systemically unwell, he would be otherwise doing okay, well and fine. So pain or swelling are generally the most stereotypical and vague complaints at presentation. And patients usually remain afebrile without any abnormal inflammatory markers, and there are no signs of systemic illness. So that's why it's a challenge to diagnose, because as we can imagine, in a kid 10-12 years old, if someone comes with pain, you can assume that they play a lot. So they could have cramped it, they could have hit it somewhere, and without any alarming features, you tend not to investigate and give them some symptomatic relief. However, we'll discuss how it can progress and what it can form into later on if it's left undiagnosed. So yeah, so these, as I mentioned just now, they're symptomatically treated until the pathology becomes clearly apparent to the assessing clinician, which should not be the case because this leads to patient and parent anxiety, also a delay in diagnosis and treatment of the patient. So case presentation. So what happened with here was we saw an 11-year-old girl, and she was referred to the pediatric assessment unit because she was there was a report of a lesion on her distal tibia, and the patient originally had an X-ray in community, and that X-ray led to the GP requesting an MRI scan, and that MRI scan was not reassuring, and that MRI scan triggered a further investigation, and the patient was sent to the emergency department, the pediatric assessment unit, to be assessed by the orthopedic team, which involved me, my registrar, or obviously a pediatric orthopedic consultant. Yep. So the patient was requested to come in for an urgent review over the weekend. Again, that's something patients would not be very comfortable with. When you come over the weekend, it generally means that it's something urgent or important or something not right. This is the lesion that was seen on the X-ray. So this is quite an alarming lesion. If I see it for the first time, I would be quite alarmed. In an 11-year-old girl, that is something that's not very reassuring, and it definitely looks catastrophic. So what was the story? So when we saw the patient, what did we find out? So basically the patient, according to the father, and when we checked our records, it was around 2 to 3 years before this incident that the patient presented to A&E with the limb pain, basic ankle pain, and it was atraumatic, but it was thought that patient might have had an ankle sprain or ankle cramp. And what happened was she was investigated at that time. So she had ankle pain 2 to 3 years ago. So she was investigated, bloods were fine, she was otherwise okay, afebrile, eating and drinking, no other problems. And they did an X-ray just to make sure everything was fine. So we'll have a look at the X-ray. This is the original X-ray. So there are a few learning points to be gained from this X-ray, which we'll discuss later on, that why this X-ray is not a good X-ray when assessing a patient with limb pain, and what it should have included in the first instance. However, in this X-ray, you cannot see anything abnormal. And the main thing is the part that we saw above is not included in this X-ray. And that's why you can't see if that lesion was present 2 to 3 years ago or not. So this kind of leaves us in a bit of a conundrum again, and a bit of a confusion. Is this the same pathology from 2 to 3 years ago, or is this a new one? However, after this, the patient was discharged with some symptomatic relief and painkillers. What happened after over the course of the next 1 or 2 years. And initially, the patient and the parents ignored it because the investigations were fine. There was nothing abnormal. However, in the last year, the patient started having significant problems. So the patient would have intermittent on and off pain. And the main question here arises, why then did she present here? So she visited the GP multiple times this year because of the worsening of the symptoms. Again, no alarming features. The GP examined the patient. There were no alarming features, no fever, no trauma, no skin changes, no symptomatic illness, and systemic illness, sorry. And patient was otherwise well. The only feature was that she was having worsening of the pain, and which was not settling. And because of this complaint, an X-ray was requested. And this is the other film of the X-ray that we saw previously, AP view. And this again shows a lesion in the distal tibia. So now the MRI was done following this X-ray because this X-ray was alarming and they wanted to investigate this X-ray further. So they requested an MRI, and let's see what the MRI showed. So this is one of the pictures of the MRI. And this looks very serious on the basis of just the imaging. If someone is looking at it for the first time, they would definitely get alarmed. And MRI report basically suspected or mentioned that it suspected bone tumor and the patient should be investigated further. And after this report, the patient was called in, and that's when we were reviewing the patient. Now, the issue here is that there are a few things that are very important when such a case presents, because we were seeing the patient for the first time and we had a suspected diagnosis of a bone tumor, and the parents, especially the father who was accompanying the child, was quite anxious, and understandably so, because the child was having pain for quite a few months and 1 to 2 years now, and it was not being diagnosed. And now they had an X-ray, then a bigger scan, an MRI scan, and now they were called over the weekend. And the dad was visibly distressed, and the dad was thinking that something has gone wrong and we have missed something for the past 2 years, and now that would lead to a catastrophic outcome for his child. And he was quite I can see where he was coming from. So we examined the patient. So what was the current situation now? So otherwise she was fine, but the only thing was she was unable to weight bear on that leg. So she was not able to put any weight on the affected limb. And that was the main distressing feature in this presentation. And the dad was worried that if it's something that's grown significantly inside, we might need to amputate. That was one of the concerns from the father, that would you need to amputate the leg? Would she be fine? Would she be able to walk? Is it gone anywhere? And even though we did not say that this was cancer, even though we did not say that this was something, we can say, sinister going on, however, the way the events happened, this was the impression that he got, because they had a small scan, a big scan, and then they were called urgently to come over the weekend, and that's how things progressed. And he was quite scared. And the thing was, the patient was also very scared because he was seeing our reactions. So what did we see when we examined the patient? Examination and investigations. So the patient had circumferential ankle swelling and more on the lateral side. However, there were no skin changes. It was tender to touch, but no significant erythema, no significant, you can say, discharge, no sinuses, nothing else. Just the swelling and some tenderness. And on mobilizing, the patient was unable to weight bear. She was limping on that leg. Bloods were normal again. Bloods were normal, eating and drinking fine, no fever, otherwise he was okay. So what did we do now? So basically, because it had become a complicated case with a long history and vague signs and symptoms, the patient was referred to the Regional Pediatric Orthopedic Center. And from there, the patient was sent home because we were awaiting a response. So a few days passed, and finally we received, we got a diagnosis with a multidisciplinary approach. We were in contact with the orthopedic center, Regional Pediatric Orthopedic Center, and finally a diagnosis was made, and that diagnosis was Brodie's abscess. So this was a relief, basically. This was a relief for all of the people looking after the kid, and especially for the child and the parents as well, because now we knew that we could do something about it, and hopefully the patient would be fine. So what did we do? So yeah, we listed the patient for elective, semi-elective or early elective surgery, and she underwent surgical curettage. So now I'll show you some pictures and you'll understand that if Brodie's abscess, the progression. So if she was left undiagnosed for a few more weeks, let's say, someone would have definitely noticed it because of how it looks now, or how it looked when she came for the surgery. So that's how the abscess looked when she came for the surgery. So it had extruded out. It was coming out through the skin when she was here for the surgery. So these are all clinical pictures taken before the procedure. So they opened it up, the orthopedic surgeons, they opened it up, they curated all of it, they cleaned it all out. They sprayed some vancomycin in it, and they drilled some holes. And I believe the holes were drilled to encourage blood supply. And yeah, and she was started on long-term antibiotics. So that's the typical treatment for Brodie's abscess. I believe it's surgical curettage and removal of the abscess, and then we put them on long-term antibiotics. She started on 2 weeks of IV antibiotics, and then she followed it up with 2 weeks of oral antibiotics. So cultures were sent when we did the curettage intraoperatively, and the culture was reported as Staph aureus. Staph aureus is the commonly typical organism seen in Brodie's abscess, reported as, yeah. Follow-up and recovery, that's the good part. So she was seen in 6 weeks time in orthopedic clinic, and X-ray was done on arrival. So what was the outcome at 6 weeks? So with such a lesion which was growing inside, and when you see the images, you get alarmed, and we were thinking that it might be some kind of bone cancer, she might lose a leg. What was the outcome when she came with the diagnosis of Brodie's abscess, which was treated? What was the diagnosis after she was managed? So she was assessed to be doing clinically well, and the X-ray showed good evidence of healing. So I'll show you the X-ray. That's the happy ending. That's the happy ending. That's why it's a good story, to be honest. Yeah, so that's the X-ray after 6 weeks. So we can see it's completely healed up. It's very nice. It shows very nice healing. Patient was fine, walking along, and that's the beautiful part. So yeah, at the end of the case report, the presentation, what were the learning points that we got from this case report, and why did we write this case report? The thing was that we wanted to highlight a typical case of Brodie's abscess, which has an insidious onset, and it can be quite a challenge to diagnose. It is difficult to diagnose, and we needed to make sure that the things that were not, the things that could be improved in this scenario, we can highlight them, so that when a similar child comes in the A&E in the future, and this case report can guide the approach towards that somehow. So when the images the X-rays on the first presentation, when you see a child, should be good quality, and ideally should cover sufficient length of the bone above and below the joint or the area of concern, so that proper assessment can be made of the metaphysis, physis, and epiphysis of the affected area or the bone that we're imaging. Communication with the parents or the patient, depending upon how old the patient is. It should be important that although the appearance of the lesion can look alarming, it may look alarming, care should be taken that we're not communicating to the patient or the family that this is a definite diagnosis of bone cancer. You have to stay neutral, you have to be honest that you don't really know what it is, and we'll know more once the diagnosis is made, once we have the reports, once we have a bit more information, because this would obviously cause more anxiety and panic. And even if you say this is nothing, that also gives false information. So you have to say what is the truth, and you have to say you don't know at this point in time, and we would know more when the information is there. But there's no it's not one way or the other. We are still in the middle somewhere where we don't know what's happening, and we're investigating this further. Treatment options. Generally, the treatment recommended for Brodie's abscess is surgery with long-term antibiotics, as we discussed in our case. And prognosis, yeah, the prognosis is quite favorable with very low chances of recurrence and permanent disability. So the evidence of all of these I've attached in the references. I'll share a link to the case report as well, so that if anyone is interested can have a look at the complete case report. In conclusion, clinicians must evaluate pediatric patients or young adults who present with atraumatic appendage pain carefully, keeping Brodie's abscess in mind to avoid complications and risk of long-term disability and complications. So basically, in young people, it's very important that if they have atraumatic limb pain and they're coming in and it's not resolving, then it's good practice, or it would be logical to have somewhere in mind that it can be Brodie's abscess, or at least get good quality X-rays which get good exposure and show you sufficient length of the area affected. These are all the references that we use for the case report, and that's the case report. It's published on Curious, Brodie's abscess, a diagnostic conundrum. And yeah, thank you. I hope you enjoyed the case report. For us, it was a very interesting case and a very interesting literary experience to write this case report. If you have any questions and answers, I would be happy to take them.